Hi friends, this is a video on cerebellar function tests. Today I was observing a student performing these tests on a subject, and knee heel test, he asked the subject to first with eyes open and then with eyes closed, the knee heel test, if you already are aware of it. Then the subject himself said, no need to close the eyes because I am unable to see my knee or heel anyways, so it's as good as closed eyes. Yes, there was a point in it. So, there are lots of aspects of the cerebellar function tests which are not fully explained to the students, and therefore they just perform these tests as mentioned in their journals. Let's have a look at these tests, but before that, let's have a quick recap of the cerebellar functions. Some of the important functions of the cerebellum are as follows. Coordination between muscle groups. I mean, if you are performing a particular voluntary movement, it requires a lot of coordination between various muscle groups, and that's the job of cerebellum, to achieve that coordination. Then performing the alternate rapid movements, because if you are performing the alternate rapid movements like pronation, supination or any such movement, you can't perform them consciously. It requires an unconscious proprioception going at a very rapid rate to the cerebellum, and cerebellum can perform them. So therefore, that's the job of cerebellum, not the job of cortex. Then cerebellum also exerts some influence on the muscle tone. So these are some of the important functions of the cerebellum. I'm only mentioning those functions which we are going to test later, although cerebellum has lots of other functions as well. Keep that in mind. Now let's see that function which we are going to test. Cerebellum, first of all, is generally called as master coordinator for the voluntary movements. Yes, cortex and basal ganglia, they have planned and programmed a particular movement, and then cortex sends the signals down on the spinal cord and starts the movement, initiates the movement. But after that, cerebellum takes over, and that movement is completely coordinated and made very precise and smooth by the cerebellum. So cerebellum is in charge of any voluntary movement once it is initiated by the cortex. So this diagram shows the circuit which will be required for us to understand the cerebellar function test. So let's say cortex has sent the signals down on the spinal cord and from there to the muscles, and muscles have begun their contractions. So the movement has begun, movement has started. Muscle length is continuously changing, and this changing length of the muscle means changing joint position. So it's called as proprioception. But this is going to be unconscious proprioception because this will not be sent to the cortex. This contracting muscle sends the signal back to the spinal cord. The signal is unconscious proprioception, and via the spinal cord and via spinocerebellar tract, the signals reach the cerebellum. Now cerebellum already is aware of the intention of the cortex, and now it starts getting the signal from the muscles which are contracting. So cerebellum will compare the two and then send the signals back down on the spinal cord, and from there to the muscles, those contracting muscles, and adjust those contractions so that the movement is very, very precise, smooth and well coordinated. So this is the function of cerebellum. But I want you to note one point here, that is, there is a sensory aspect to this entire movement, that is unconscious proprioception. Muscle contractions and their changing lengths are sent back to the spinal cord, that is, signals are sent back to the spinal cord, and from the spinal cord the signals are ascending upward in the spinal cord and are finally reaching the cerebellum. So this is the sensory aspect of it. And then the motor aspect is that the cerebellum will send the signals down on the spinal cord, on the anterior motor neuron, and then adjust those contracting muscles or adjust the contractions of those muscles. That's the motor part of it. Having said this, now let's see the cerebellar function tests in the light of some of these functions. No tremor at rest, but there is intention tremor. That's a classic sign of cerebellar function, cerebellar disease, lesion in the cerebellum. So you can just observe the patient first. If there are tremulous hands, tremors of the hands at rest, if there is no tremor at rest, but you ask the patient to perform a movement and there is tremulousness of the hands, then it is certainly a cerebellar tremor, tremor due to the lesion in the cerebellum. Adiadochokinesia. You know, I mentioned just now that alternate rapid movements are performed courtesy cerebellum. It is because of the cerebellum that we are able to perform these movements very rapidly, alternate rapid movements. So loss of that is called as adiadochokinesia or dysdiadochokinesia, another sign of the cerebellar lesion. And the third, which we are actually going to test or examine, is the ataxia, loss of coordination between muscle groups. So let's understand this ataxia and how we perform the test. Right. Tests for coordination in the upper limb. Now basically we are going to first see the tests to check the coordination, whether it is intact or not. In the upper limb, there is finger nose test. So touch the fingertip by the other hand, by the other fingertip, and then touch the tip of the nose, finger nose test, or finger to finger test. So hold your hands, outstretched hand like this, and then bring them closer, bring them near the midline and touch the tips of these index fingers. So finger to finger test. That's for the upper limb. For the lower limb, knee heel test. That's the only test which I won't be able to actually explain, because this is generally done in the lying down posture. Heel of one foot is touched on the knee of the other limb, and then slide that heel along the shin. So that is called as knee heel test. Some of you might have already performed these tests in your practicals. Okay, Romberg's test. Ask the patient to stand straight up like this with feet touching each other, feet close to each other. Stand like this, stand right in front. That's Romberg's test. And tandem walk test. That is, ask the subject to walk in a straight line, feet going one after the other in tandem like this. So that's a tandem walk test. That's for the lower limb. These are the tests for the lower limb. Now some important points to be remembered. First thing, each test has to be performed twice. Once with eyes open, then with eyes closed. Why? I'll discuss it a little later. But remember this, first with eyes open and then same test with eyes closed. All right. I don't know how many of you will be able to perform this finger to finger test with eyes closed. And does it have any significance if your fingertips are not touching each other? I'll mention that also. But that's the point number one. And use some common sense here. For example, knee heel test. The person is lying down and performing the knee heel test. He or she can't see that knee heel test. He can't observe himself. So eyes open or eyes shut doesn't matter actually for this test. Second point, and the most important point to be remembered, is that while you are performing these tests, mind you, you are suspecting cerebellar lesion, which means the patient will not be able to perform these tests, particularly in the lower limb. Ask the patient to stand straight up like this, and if the patient is having some kind of ataxia, the patient is likely to sway and even fall. That's a possibility, and therefore do not forget to stand behind the patient like this as if you are trying to get his balance in case the patient goes off balance. So that's a very, very important point to be performed in your exams or while you are checking the patient. So whether it's a tandem walk test or a Romberg's test, you are anticipating that there is a possible ataxia and the patient might falter, might sway and even fall down. So obviously do not allow that to happen, and therefore always stand very close to the patient. In case the patient sways and about to fall, you can give him some help. So these are the tests for upper and lower limb respectively. And now let's talk about the ataxia and understand the significance of these tests. First thing, ataxia means loss of coordination. Taxis means movement, so unable to perform the movement because of loss of coordination. That's ataxia. And this loss of coordination or ataxia is of two types, or it is because of one of the two reasons. Either it could be sensory ataxia or it could be motor or cerebellar ataxia. Well, there is one more type which is called as vestibular ataxia, but it's quite similar to the sensory ataxia, so I am not describing it separately. Let's concentrate on these two. Either the cause is sensory or the cause is motor for that loss of coordination. Let's understand what these sensory versus motor ataxia are, and therefore let's understand also why the tests are performed first with eyes open, then with eyes closed. So let's go back to our diagram of the cerebellar circuit. Right. To perform any movement, as I mentioned, to perform a movement smoothly and precisely, we require this circuit. Now in this, there is a sensory component. The muscle contraction starts, and as the muscle contraction starts, there is moment to moment change of length of the muscle. Now this information, which is called as the proprioceptive information, it arises from the muscle and goes back to the spinal cord. We are calling it as unconscious proprioception because it's not going to cortex, it is going to go to the cerebellum. So this proprioceptive information goes back to spinal cord, from the muscle to spinal cord, and then it ascends upward in the spinocerebellar tract. It's a sensory tract, the spinocerebellar tract. It is carrying unconscious proprioception into the cerebellum. Now consider a spinal cord lesion or degeneration of neurons in the spinal cord. What is likely to happen is that the information from the muscle will not reach the cerebellum because it has to ascend in the spinal cord and reach the cerebellum. That's not happening. And if the information from the muscle, contracting muscles, is not reaching cerebellum, then cerebellum will not be able to take any further decisions. It will not be able to take, send the signals further again back to those same muscles, and will not be able to adjust the contractions. Now this is called as sensory ataxia because there is loss of sensory input. There is loss of sensory signaling into the cerebellum because of the spinal cord lesion. The other type of ataxia is motor ataxia. Imagine if there is a cerebellar lesion. Even if the information is reaching the cerebellum, even if contracting muscles are able to send the signals via spinal cord into the cerebellum, sensory information is coming from the muscles. But if the cerebellum itself is lesioned, then it will not be able to send the signals back properly to the muscles. It will not be able to coordinate the muscle groups, and the movement will not be proper and smooth and precise. So this would be called as motor ataxia. So two types: sensory ataxia, generally seen in case of a spinal cord lesion or degeneration of neurons in the spinal cord. And motor or cerebellar ataxia means lesion in the cerebellum itself. So there is no motor signaling going back to those same muscles. Right. Now let's say you are performing these tests, the finger nose test or finger to finger test and the other tests, and the patient is not able to perform the movements. It would be ataxia, loss of coordination. But then what type of ataxia? We need to differentiate. And therefore, to differentiate between sensory ataxia and motor ataxia, the tests, each test is performed first with eyes open, then with eyes shut. I'm going to repeat this sentence because this is asked very often in the vivas. Why do you ask the patient to perform the test with first with eyes open, then with eyes closed? Answer is, now by heart this answer, to differentiate between sensory ataxia and motor ataxia. That's the answer. Now the explanation part of it. Look, let's say there is a sensory ataxia, means there is no information reaching the cerebellum regarding the muscle contractions. Fine. The eyes are open and the patient is performing the movement. The patient will still be able to perform that movement. The patient will still be able to perform that test. Because although there is no information coming from the contracting muscles, but his eyes are open, there is a visual input. He can see his eye, he or she can see his muscles and joints and thereby correct the contractions and perform the movement. That's possible. But when the eyes are shut, now there is no visual input and already muscles information, the unconscious proprioception is not reaching the cerebellum because of the spinal cord lesion, and therefore now the patient will not be able to perform that movement. So is that clear? Eyes open, patient performs. Eyes closed, patient falters. This is typical of sensory ataxia. I repeat once again, because when the eyes are open, even though there is no information reaching the cerebellum regarding the muscles because there is a spinal cord lesion in between, but patient can see his joints and correct the contractions and then perform the movement. But with eyes closed, that visual input is also gone and therefore the patient falters. So I repeat once again, eyes open, patient performs the movement, eyes closed, patient falters. This is typical of sensory ataxia. And if the patient is not able to perform the test any which ways, eyes open or eyes shut, doesn't matter, the patient is unable to perform the movement, it is called as motor ataxia or cerebellar ataxia. Why? Because cerebellum itself is lesioned. Look, in the previous case, signals were not reaching cerebellum. That is why cerebellum was helpless and was unable to perform the movement in the sensory ataxia. But if the cerebellum itself lesioned, then whether the eyes are open or eyes are shut, doesn't matter. Cerebellum, the master coordinator, which was supposed to adjust those contractions, that itself is not functioning, and therefore eyes open, eyes shut, doesn't matter. The patient will not be able to perform the movement. So therefore that will be the motor ataxia. Remember this one, I am going to repeat it one more time just for your examination purpose. Eyes open, patient performs. Eyes closed, patient falters. This is typical of sensory ataxia. Eyes open or shut, doesn't matter, patient is unable to perform the movement. This is cerebellar lesion. The master itself is damaged. So eyes open or shut, doesn't matter, no coordination is possible. So that's about the ataxias and how to check for the ataxias. Finally, there are some small finer details which I will add, and then we can summarize again. If you are performing finger nose test, rather than holding your fingertip in front of him, let the patient, him or her, hold his or her hand like this, fingertip, and then perform the test. so that when the eyes are closed, the patient has his own hand to just perform the movement. Very often students make this mistake. They hold their fingertip like this and they will ask the patient to touch it. Well, then with eyes closed, the patient would not know where the hand is placed by the examiner. Second thing, as I mentioned, finger to finger test. With eyes open, we are all able to perform that movement barely. And when the eyes are closed, even a normal individual is not able to perform this test exactly. Well, if the distance between the two fingers, see like this, if the distance between the two fingers is more than 4 to 6 centimeters, then you would assume that the patient has some kind of a lesion. Otherwise, it is likely to be not a very exact pinpointed touching of the fingertips. So don't worry much about that aspect. But if the distance is more than 4 to 6 centimeters between the fingertips, then yes, possible lesion. So these are some of the aspects related to the cerebellar function tests. Most important part was ataxia, loss of coordination, how to perform the tests, and don't forget to stand for the lower limb tests. Don't forget to stand behind the patient, because you are suspecting a lesion and the patient is likely to sway and fall. So remember this. Don't forget, examiner always observes all these tiny little things and expects these things from you while giving the marks. So this is in short the cerebellar function tests.